recording it though. There we go. Okay.
Right, we'll give it another minute and then we'll get started.
Hi, can you hear me?
Yes, we can hear you.
Okay.
If everybody could please put their microphones on mute, though, that would be really helpful so there's no background noise.
All right.
Thank you. So why don't we can get started. Hi, everyone. Thank you so much for joining us today. My name is Jill Feldman. I am a lung cancer patient, advocate, and a co-founder of the EGFR Resistors. And for the EGFR Resistors, education, connection, and access have always been at the heart of what we do. And now that we are officially a nonprofit, we're expanding those resources and, I think really getting into what's important, and especially when it comes to topics that are urgent or emerging and often, under discussed, yet are great needs within our community. And our goal is to do that in different ways. Leptomeningeal disease and brain metastases in general is one of those topics. And so today we're bringing together knowledge, expertise, and the lived experience to shed light on this challenging topic, and more importantly, to offer hope. But before we get started, just a couple of housekeeping notes. Please submit questions if you have them in the chat function, because there will be time for Q&A. And please keep your microphone on mute so we don't have background noise making it difficult to hear the people speaking. So let's meet our incredible speakers. We are so fortunate to have two outstanding clinicians with us, both head thinkers and heart thinkers, both deeply committed to improving outcomes for people with lung cancer, and part of a team that is making that possible. First, we have Dr. Laura Alder. She's the thoracic oncologist at the Duke Cancer Center and deputy medical director of the Duke Center for Brain and Spine Metastasis. Dr. Alder's clinical interests include advancing translational research and clinical trials to improve outcomes, including her tireless efforts to expand options for patients whose cancer has CNS involvement. We also have Dr. Trey Mulliken. He is a radiation oncologist at Duke University, where he specializes in lung and brain cancer and metastatic disease. At Mayo Clinic, he trained as a physician and is now the Deputy Spine Services Director of the Duke Center for Brain and Spine Metastases. He champions multidisciplinary care for patients with complex disease, which is absolutely critical to have that multidisciplinary care. And now we are honored to have Allison Vong with us. You'll hear more about Allison's story during the conversation, but her perspective as a caregiver and an advocate is one of the most important perspectives. It's the strength, the love, the fierce determination that caregivers really dedicate themselves to while caring for their loved one. Allison has walked this path with her mom for 7 years through multiple relapses, uncertainty, but again, most importantly, hope. And I think their story is one of science and heart. And we are so grateful she's sharing it with us today. And I also think actually our story is a testament to precision medicine, persistence, strong relationships with her care team, and the power of really being able to make informed decisions. And we hope to, empower you to make informed decisions after today. So without further ado, I would like to introduce Dr. Laura Alder is going to start off our webinar.
Thank you so much for that really kind introduction, Jill. So happy to be here with all of you. Thank you to Dr. Mulliken and for Allison for joining and for kind of co-hosting this along with us all. So I'm going to share my screen. And then at the end, we will definitely have time for questions. I saw a few really good ones already in the chat. And so this presentation is when EGFR positive lung cancer spreads to the brain, including brain metastases and leptomeningeal disease, and we'll get more into details with that. Standard disclosure, as well as some of the research funding that we get, but this doesn't affect the presentation at all. So we're going to start off with a patient case. This is likely familiar with a lot of y'all. So a young female presents to my clinic in her mid-30s, no smoking history, no family history of cancer. She's had a persistent cough, went to see her primary care doctor. That led to an x-ray, said, you likely have pneumonia. Here's some antibiotics. About a month or so later, she's still feeling really unwell. She's still having this cough that's really bothersome, limits how much she can play with her kids. So finally, a CT scan is done, a CT of the chest. And you can see what that showed here on the right. It showed a pretty large lung tumor and a lot of pleural effusion, which is fluid around the lungs. That's all of that kind of more solid white things. And you can see on the other side with the black, that's a healthy lung full of air. And so it was really concerning how that lung looked. So that gets into, the next steps. What happens when we see a lung tumor that's concerning? What happens when there's fluid in their lung? So we ordered further imaging to what's called staging, so we can know exactly where the cancer is from head to toe. Some of that fluid was drained. And that made the diagnosis when we sent that off for pathology, the diagnosis of lung cancer and the subtype adenocarcinoma, which is the most common type. And while we were working that up, we started off by sending a blood test for biomarkers, and that test for things like EGFR mutations or deletions. And so I'm sure a lot of you have this experience. I wanted to ask Allison, kind of what was your experience when your mom was diagnosed?
Yeah, and just to reintroduce myself really briefly, my name's Allison Vong. I'm here, representing myself and my dad as patient advocates to my mom, who was diagnosed with lung cancer in 2016, coming up on 10 years now. And as Laura shared, her experience was very similar to the case study that was just described. My mom presented with a cough for several weeks. She got a chest x-ray, which did show some sort of mass, but again was thought to be some sort of bacterial infection. She was treated with antibiotics first. A repeat chest x-ray continued to show the mass unchanged. we were in Arizona, so she was then thought maybe she had valley fever. So she was diagnosed with valley fever, but the blood tests were negative for that. And finally, she was sent to a pulmonologist, and they did a bronchoscopy where they found atypical cells that were symptomatic for adenocarcinoma. So finally, she was able to get a PET scan, and had a follow-up lobectomy to just remove the lower lobe of her right lung. Um, and so they continued to surveil the lung for 2 years. She had no progression in the lung. Everything looked good, and it felt like it was a remission, from a stage 1B diagnosis. But unfortunately, about 2 years later, she started to experience headaches. And it was really difficult to get a brain MRI at that time. She didn't have any brain involvement at the time of her lobectomy, so there was, I think, minimal reason for doctors to feel like they should image her brain. And despite kind of multiple attempts to get a brain MRI, it was just not approved. So eventually, my parents had the great idea to go to their family doctor and try to get a brain MRI that way. And unfortunately, that brain imaging showed brain metastases in her brain, as well as suggestion of a possibility of leptomeningeal disease. So sadly, from what I understand, the story that Laura shared is not an uncommon anecdote. And this delayed diagnosis is very common. In my mom's case, twice, for the lung, and then again for the metastases. So I think about it all the time, if the family doctor hadn't agreed to do a brain MRI, or even more so, if my parents hadn't thought to be creative and find a different avenue of trying to get a brain MRI, we might be in a very different position today. So yeah, I think my mom's experience, as well as that of, I think, many others that are very similar, really highlight how important it is for patients and for their loved ones to advocate for themselves throughout the entire journey of this type of a diagnosis. But even at the start, even at the point of diagnosis, I think Laura said it really nicely the other day that, the patient and their family knows their body best. And if you feel that there's something wrong, it's worth advocating and trying to understand what could be causing that.
Thank you so much, Allison, for sharing your story and your experience with your mom. I'm sorry that y'all had to go through that.
Thank you.
And so just building upon what Allison was kind enough to share, so we did get a PET-CT scan, which is when a sugar dye is mixed with nuclear dye, and that helps us to understand where the cancer is. The fast growing cells, like the cancer cells, light up really bright. Some of the normal body structures also light up, like the brain like sugar, that's the fuel. So we always get a brain MRI every single patient whenever they're diagnosed or has high suspicion for lung cancer. We always order a brain MRI so we don't miss anything when we start planning and discussing treatment options. So this patient got that PET-CT scan to help stage, know where the cancer was. She got a brain MRI. The PET-CT scan did show that lung tumor, the fluid around the lungs, and some lymph nodes in the center of the chest, as well as some cancer, some tumors in the spine. The brain MRI did show a mass that was concerning, that the lung cancer had spread from the lungs to the brain. An MRI spine was done because that PET-CT scan did show tumors in the spine. MRI scans are the best scans that we have to take a close look at the brain and the bones, especially the spine. And that did show cancer in the spine as well, with tumors in the spine. You can see here, this is when we talk about staging, this is what we mean. It means that we know that this is all lung cancer. It just depends kind of where that lung cancer starting off in that lung wherever it started from, where it spread throughout the body. Some of the first places in the lymph nodes. And then unfortunately, lung cancer is one of the cancers, all types of lung cancer, that unfortunately does tend to have a high occurrence in the brain. So these were her biomarkers. Really important to get biomarkers at initial diagnosis, and any time when the cancer seems like it might be growing again. We'll get into that a little bit later. So for her, we did find what's called an exon, an EGFR exon 19 deletion. It's called one of the common EGFR mutations. So we talked a lot about treatment decision making, the options, which we'll get into very soon in this presentation. And so she got started on carboplatin and pemetrexed, in addition to the pill osimertinib, also known as Tagrisso. Thankfully, this was her scan. On the right there, you see the scan of diagnosis. 6 weeks after starting these 3 treatments, 2 chemotherapy IV drugs, and the oral pill Tagrisso osimertinib. This was her scan. Amazing results. She was feeling so much better. She was able to play with her kids again. The cough improved. And this was her brain MRI. You can see on the left was the initial brain MRI showing that little lesion where the arrow was. And then on the right there, you can see that pretty much resolved after 6 weeks with these therapies, which we've seen in a lot of cases. Really, thankfully, these drugs get into the brain very well. And that's one reason why in this patient, we did not perform radiation treatment to her brain. And we'll get into that a little bit later, but we felt confident in just giving systemic or whole body treatments first, like the Tagrisso and the chemotherapy. So to take a step back, what are brain metastases? So this is the lung cancer that has spread to the brain. It's not a new brain cancer. It's still that same lung cancer. And so when we say CNS activity, that means the central nervous system. So that includes the brain tissue. It includes the leptomeningeals, which are the lining of the brain, and the fluid and the CSF, the fluid around the brain and the spinal cord. Obviously, the brain is a really precious structure. It has a coating, a thin coating, just like the lungs do, which is that membrane, the leptomeningeals, and then there's that fluid to kind of provide that cushioning, that support. And all of the above are what's considered the central nervous system. And like I mentioned before, we always get CNS or brain imaging because we know that lung cancer tends to go to the brain. It can be there at initial diagnosis, and it can come during the course of the treatment. And in EGFR mutation positive lung cancers, we know this happens even more often than any other type of lung cancer. So this is what makes it really relevant to this group. A little bit how cancer spreads to the brain. We know that there is that blood-brain barrier. Whenever there's cancer in the body, that kind of changes all of these dynamics. So we know in metastatic stage 4, when cancer starts spreading, one of the ways it does that is through the bloodstream. So these lung cancer cells get into the bloodstream, and they make changes. They release these molecules, these substances. They like to break things down. They like to find new places they can call home. So you can see here how the cells can kind of stick to the blood-brain barrier between the blood vessel and then like the brain itself, and they make changes. And they can kind of get through, and you can see on the right, they make their own doorway. They can kind of sneak into this protected area. These are some of the common symptoms of brain metastases. Ideally, when anyone's on treatment, we'll be monitoring the brain throughout treatment. But any of these symptoms are emergencies that need to be brought up to your treating oncology doctor right away. So how do we make the diagnosis? We talked about this a little bit. The brain MRI is the best scan that we have. There is no radiation. It uses large magnets to visualize the brain structures. It can take anywhere usually of around 30 minutes, sometimes a little bit longer. It can be a bit claustrophobic. It can be a little bit of a tight structure. Everyone does everything that they can to make it as comfortable as possible. Oftentimes playing music. There's some medicine that can be given if you know that you have problems being in a closed structure, which is very understandable. Tell your doctor, like, hey, what can you have to best support me to get through this? An alternative, if MRI is not possible, is a CT scan of the brain with and without contrast. That uses X-rays. It's a little bit quicker. It's still a helpful examination. There's no blood test that can help us diagnose the presence of any cancer in the brain or the spine. But we know that the biomarker assay, that the liquid test, does do a very good job of detecting biomarkers such as EGFR. So I'm gonna throw it back to you, Allison. We talked a little bit about your experience when your mom was diagnosed. Is there anything that you wish you would have known at the time of diagnosis of the brain involvement?
Yeah, I think there are quite a number of things. The first thing is largely a lot of the things you had just discussed, how common a brain metastases is in people who have EGFR positive lung cancer. At the time that my mom was diagnosed, as I shared, she had gotten a brain MRI, and when she found brain metastases and possibility of leptomeningeal disease, she was actually held at the hospital that day because the tumor was hemorrhagic. I think it needed to be taken out immediately, I think due to the pressure. And so that experience was extremely overwhelming. You can imagine kind of going in to get a brain MRI from your family doctor, thinking that you just have headaches and just trying to kind of get peace of mind. And then being held and told that uh, you thought you were in remission, but you actually have stage 4 cancer, understanding now for the first time that it can spread to your brain, trying to get a wrap around what this LMD, leptomeningeal disease, what does that mean? As Laura said, like, what is the CNS space and why do certain medications not make it past that blood-brain barrier? How is that different than a normal EGFR lung cancer diagnosis that hasn't yet spread to the brain? So yes, I think it was emotionally extremely overwhelming, but I guess from a more practical perspective, I think a brain diagnosis like this, a brain met diagnosis, really gave a different perspective in that there was a real sense of urgency. It wasn't like the first time that lung cancer was diagnosed, where she was able to kind of schedule out a lobectomy and go through that kind of process. She had a prognosis of only 8 weeks at that time. And so I think, yeah, the urgency, the sense of urgency, and just the way that we approached this second round of this brain met diagnosis was different than the first time. Building on what I wish I had known, I think it's important to understand from your doctor what you think of your prognosis is. However, I would also add that what I wish I had known at the time is that the field of medicine really is changing. It's kind of one of those rare examples where the past does not really define the future. And I think looking to, the diagnoses of the past, the prognoses of the past, is useful, but it's also important to recognize how fast the field of medicine is changing. So I think that's something I wish I had known. Obviously, also having a group like this to access, to share both how you're emotionally doing as well as practical advice and experiences is super helpful. And then one thing that I was really fortunate for, I would say, was that when she had her tumor resected, it was sent immediately for genomic testing. And I think that was super important to be able to confirm, first of all, that the tumor had come from the lung. And secondly, to try to pick up any new mutations that may have arisen since the first time she was diagnosed with lung cancer. So I guess I wish I had known more clearly that that could change, the number of mutations she has or the genomic makeup could change from the first time she was diagnosed with lung cancer alone to this new lesion in the brain.
Yeah, thanks, Allison. That's really powerful, and I agree with you. There's definitely a sense of urgency. And so I appreciate what you said about hope too, which is a big theme of this presentation and this talk. So a little bit about prevention and screening. Again, brain MRI diagnosis for all patients. Our policy, at least at Duke, with especially with any actionable biomarker like EGFR, where we have these targeted therapies, but whereas we talked about there is a higher occurrence of brain involvement with EGFR, my policy is to get yearly brain MRI scans if there's no brain involvement at initial staging. If there is brain involvement, I usually get scans about every 3 months to make sure that we're doing a good job of controlling the brain involvement. And that can differ a lot, as I mentioned before. If we start treatment first and are keeping a close eye on the brain, sometimes we get another brain scan in about 6 weeks to make sure that the treatment is working. But it is important that we keep a really close eye on what is happening in the CNS in the brain. These are the few questions that I put together if you're initially diagnosed with brain mets that you can ask. Allison, anything that you would add to these before we get into some of the treatment options?
Yeah, I think these are great. Maybe I would also ask, how long will it take to know whether a certain treatment is working? That can help to decide how quickly you want to shift your treatment options. What do the signs of progression look like, right? It's good to be kind of proactive and be able to be alert about what progression might look or feel like. And then, what the next line could be in case this treatment fails, just always trying to stay one step ahead. I think that sense of urgency really is, as Laura highlighted already, super critical in a brain met diagnosis.
Yeah, thank you. And as you mentioned, Allison, too, always okay to advocate for yourself. If biomarker testing hasn't been done, it's okay to be like, hey, I need biomarker testing. Has it been done? What are you thinking?
Yeah.
And then thankfully, as far as resources, we have this great group. So treatment options, lots of different options. Dr. Mulliken will talk about radiation. We have chemotherapy. We have targeted therapy. So going to some of the frontline options we have in EGFR are positive. These are some of the frontline options we have for the common alterations, EGFR exon 19 and 21. You can see that osimertinib is pills. We have IV treatments like chemotherapy and amivantamab. These are some of the considerations we think about, and when we're discussing a shared decision-making strategy. These are the factors, but as below, as you can see with the doggy door, I'm a big fan of dogs. One size doesn't fit all, right? Every patient's different, every case is different. That's why it's so important to have shared, informed decision making. And every patient sitting in front of me is a unique patient and needs a unique and specific talk. This is a comparison of some of the frontline options we have. And again, the common EGFR exon 19 deletion or exon 21 mutation. You're probably pretty familiar with, FLAURA2, Mariposa, using any one of these treatment lines. Thankfully, we still have some ways to go, but they've done a really good job of improving survival. There are some trade-offs to that improved survival with a little bit more toxicities whenever we combine treatments, when we add on to the Tagrisso, to the osimertinib chemotherapy or amivantamab. Lazertinib is very similar. It's the same type of third generation EGFR pill. And as you can see here, though, we've come a long way. You can see in CNS involvement there. Patients are living longer without growth in the brain, PFS progression-free survival. So it means the time until we see growth or new lesions anywhere. And in patients with CNS, we're specifically including those who have the brain involvement. We always have to think about toxicities. Toxicities, as Jill does an amazing job whenever she speaks, what's tolerable differs a lot between patients. It's not only how severe it is, how bad it is, but how long does it last? What does that look like in everyday life? Thankfully, there was a Cocoon trial that was a great randomized trial that's looked at how we can improve preventative care in rash specifically. And because of that, with a lot of these trials and the combination with amivantamab specifically, you will get pretty much like a care bag if you start it that includes pills like antibiotics to prevent rash, lotions, rinses. And I think thankfully the field of oncology is really moving towards incorporating quality of life in addition to how well these treatments work, which is super important and something that I think we all think about a lot. So for some of the uncommon alterations, we know that they can be for uncommon, they can be fairly common. We see them in clinic. And so for EGFR exon 20, we use amivantamab with chemotherapy, carboplatin, and pemetrexed. There's a new agent that was just approved based on the Wukong trial. It's still kind of slowly making its way to the USA. That's a sunvosertinib. It was started off in China, but the data is great, and eventually we will have hopefully easy access to it in the US too. And then for the atypical alterations or the uncommon ones, you can see here, it's pretty much everything other than EGFR exon 19, 21, and 20. Usually we use either afatinib or osimertinib. Both are pills. Both have a pretty good activity in the brain. And again, this is why biomarkers from the tissue and or the blood, oftentimes both, are so important to help guide treatment options and to pick the very best frontline treatment for the person sitting in front of us. As I mentioned, we have to weigh the pros and the cons, pills versus IV versus how well the treatments work versus how will they make you feel. What's the schedule like? How would they affect you, your family, etc.? And so these are all the things that we talk a lot about the first visit and the first couple visits to make sure, and like we said before, one size does not fit all. So Allison, I know I said a lot of information here. What stands out to you in the frontline setting as trade-offs and how we think about these options?
Yeah, I mean, I think your example of the dog was a great one. I think this is different. Everyone is different, both physically as well as just what they consider a high quality of life to be, right? So the side effects may not be the same for everyone, both as you said, in terms of length and variety, but also, what people consider a high quality of life, which I think is what everyone is trying to optimize for, is different. So all of the options Laura shared are amazing. Those first line options, my mom has actually been on all of them. She had a great run on osimertinib Tagrisso at 80 milligrams and then re-challenged at 160 when leptomeningeal disease returned. She's currently now on amivantamab and is doing great on that as well. So yeah, to jump the gun a little bit here, I guess my take on these first line options are just that it's crazy to see, having started this journey nearly 7 years ago now, that these are considered first line options today, and then they weren't, 7 years ago. So that I think that just kind of reiterates this concept that what's first line is constantly changing, that the space is constantly changing, and again, to reiterate how important it is to just keep getting genomically tested to stay up to date and be aware of what the options are today.
Yeah, thank you, Allison. And we'll get into it soon, as you very nicely said. Just because you don't get one of these options up front, they can still very much come into play if or when needed down the road. And so I think a message of today is there is lots of hope. There's so much research, as Allison, you said a few times now, that I love. This field is changing so quickly. And that's one of the reasons I love my job. That's one of the reasons I love being a clinician in clinic and being a researcher with clinical trials and improving this field. We have new approved options every few weeks. There's so many clinical trials ongoing, new pills, new combinations, newer generations, beyond osimertinib. So it's an exciting time. And we talk a lot about clinical trials. And there's different phases. You might hear that when you go to an oncology doctor, like, oh, a phase one, which is really early in development, versus a phase three, which is a bit later in development. One thing that I really say is oftentimes, the best treatment that we can give is a clinical trial. We would never be offering a trial if we didn't feel like this was a great option, like this could beat the standard of care. And sometimes it's a single arm where all you get is the study drug. Sometimes you can be randomized. So sometimes some people get the study drug, some people get the standard of care, which we would do anyway off of the trial. And that's important when we compare outcomes. But just a shout out to clinical trials in general. It's how we move the field forward. And none of us would offer something that we didn't think we wouldn't offer to our loved ones, to ourselves. So a lot of thought goes into what we bring on. So what happens when cancer grows after the initial treatment? Always important to repeat the biomarker testing. So that can be done on the cancer tissue. If it's safe to do so, we repeat a biopsy. And so that can be from the lung. If the cancer's in the liver, we can biopsy a liver. And that's a really good way to do it if it's safe to do so, because we can also make sure, some of you may have heard of EGFR cancer can transform into small cell cancer. It's very rare, but getting tissue is an important way of assessing that. And then oftentimes we also, or sometimes instead of, get blood biomarkers. That's a simple blood test. And both of these tests, it really looks at the DNA, which is like the instruction manual that tells the cells what to do. And sometimes mistakes happen in that instruction manual, and that's what causes the cells to grow out of control. And that is what cancer is. And by doing biomarker testing, we pick up on things like EGFR mutations, on what's called resistance mutations that can help us pick the next treatment option. And so Dr. Mulliken will talk a little bit more about this, but if there's only 1 to 3 sites, and that number can be different compared depending on what's happening. Sometimes we continue on, for example, osimertinib, and we just zap using radiation the couple tumors, and then continue still on a drug like osimertinib to really get, well, I describe to my patients, we want every drop of benefit we can out of a really good drug, out of a really good therapy. And then when we do have to switch therapies, so many good treatment options, so many more in trials. These are a few of the second line treatments that we have and beyond. So we have new pills that are the TKIs, tyrosine kinase inhibitors. We have, if we do find something on biomarker testing, like in that second box there, a MET amplification is one of the more common ones, or HER2 or ALK. If we find kind of different modes that the cancer is growing, we have antibody drug conjugates, and I don't want to get too into the weeds. This slide is kind of just to say we have a lot of options. And that's kind of the message here. One of the new options that some of you may have heard of is called Dato-DXd or Datroway. That got approved a couple months ago now. It's approved for anyone who has progressed, who the cancer has grown after using chemotherapy and a pill like osimertinib. And this just shows the average time until the cancer in the brain starts growing again. It's about 7 months that patients can have really good benefit before. And whenever we talk about median, I do always like to say that's just that middle number. We have people on both sides of that. So I think that's just a caution whenever you see any of these numbers. We have some cases where unfortunately not everyone makes it to this number, but we also have a lot of cases where people make it well beyond this number. So whenever someone talks about prognosis or like specific numbers, I would just really caution it differs a lot. And all we can say is the average, that middle point. But a really good next line of treatment. And now, thank you for everyone's attention. I'm gonna hand it over to my esteemed colleague, Dr. Mulliken, to talk about radiation options in brain metastases.
Thank you, Laura. Thank you so much for a great presentation. Thank you, Allison, for sharing your family's experience. My name is Trey Mulliken. I'm one of the radiation oncologists at Duke, and I have a specialization in taking care of patients who have lung cancer, as well as patients who have had lung cancer that's spread to the brain. And it is one of my interest. And I was hoping today just to give an overview of radiation and radiation options for patients in this situation. Sorry, okay. I think we got it. So what is radiation? Radiation is emission or transmission of energy through the air or by wave or particle through any space or material. And in radiation oncology, we typically employ high doses of radiation on the spectrum of X-ray radiation or gamma ray. And there's also another type of radiation called proton radiation, which we'll discuss at the very end. So how does radiation kill cancer? In the body, ionizing radiation causes DNA damage, and both normal and cancer cells are affected. But we believe that cancer cells largely have lost their ability to repair this DNA damage, and they ultimately go through a cellular death pathway and die, whereas our normal tissue typically can repair itself. And radiation treatment, just for everyone's clarity, is measured by the unit, the gray. Laura, do you mind advancing the slide? I think we're having an issue. Thank you. So how is radiation treatment delivered? The majority of patients who receive radiation treatment for cancer will receive something called external beam radiation treatment, and that's typically delivered with a linear accelerator or a LINAC, which is pictured here. There are other technologies. One technology is called the gamma knife, which is a type of technology that does focus on treating brain metastases. And there's another technology called the cyber knife, which is also like a linear accelerator. In some rare circumstances, some patients may receive internal radiation treatment. That's called brachytherapy with radioactive seeds or tiles. There is some research looking at this for brain metastasis, but it has not become common practice at this time. How do we get a patient started with radiation treatment? The first start of this process is a consultation with the radiation oncologist, and this usually lasts for about an hour. At that consultation, if you're deemed to be a candidate for radiation treatment, we then will schedule a radiation mapping session, which is to put you in the position for your radiation treatment. That's either done that day or sometimes about a week or so later, so it'll be a separate appointment. It takes about 30 to 90 minutes total. After we do that mapping session, we then go through the radiation planning process, which can take one day, sometimes a week, and sometimes up to 2 weeks. And then we'll bring you back for your radiation treatment. And that treatment delivery takes about 15 to 60 minutes. The one difference with the gamma knife radiation treatment, the radiation mapping session, planning and treatment delivery is all done on the same day. So logistically, that can be a more advantageous technique and just help patients get everything done in one day. When I see a patient who has brain metastasis, I look at kind of multiple different things about the patient. One of the biggest drivers of what a good treatment option would be is the patient's performance status. And what we're really trying to understand is how active a patient is. And we have this scoring system of 0 to 100 that we often will use. And the goal is to really assess if a patient has enough fitness or is strong enough to go forward with a treatment. This is also used in medical oncology. In addition to looking at a performance status, I look at the cancer type. I always see if they have an actual mutation, and then see if there's what kind of systemic options there are. Any review of a patient for treatment always involves my review of their imaging and seeing, in this case, looking at the brain MRI and trying to understand how many brain lesions there are and how big the lesions are. And then lastly, I'd like to know if any of the lesions might be causing any neurologic symptoms or any problems for the patient in order to help guide the treatment options. So radiation treatment options for brain metastasis, one of the historic treatment options and an option we still use today is something called whole brain radiation treatment. This is given to patients usually over the course of 10 treatments, and it involves treating the entire brain with radiation treatment. There is a newer technique called hippocampal avoidance whole brain radiation, and that's been employed more recently as it's shown to help reduce the neurocognitive effects of radiation treatment. That's also given over 10 treatments. And then the preferred approach, if we're able to, is stereotactic radiosurgery. Radiosurgery is very focal radiation treatment where we just treat the individual lesions. And that's done either with a linear accelerator, a gamma knife, or a cyber knife. Whole brain radiation treatment. So this is the delivery of palliative dose of radiation treatment, typically over 10 treatments given about 2 weeks. This can treat a significant number of brain metastasis. So if a patient has a large number of cancer spots on the brain, the whole brain radiation sometimes is the best option. But there are some side effects that we do counsel patients about. Fatigue is really the most immediate side effect we see from patients, and this fatigue can be very significant, and sometimes in some patients can last for weeks after radiation treatment. In some patients, I've seen it last up to a couple months, so that's something I really do counsel patients about. Other side effects can include headache or nausea from the treatment. There is hair loss with this radiation treatment. It is typically temporary and grows back in a few months. The most worrisome side effect of the treatment is neurocognitive effects or cognitive decline. We know that patients who receive this treatment can have some impact on short-term memory and feel that the processing speed might not be as quick. It's very common to prescribe a medication to help protect the brain from these neurosymptoms, and that is called memantine, and that's usually given for about 6 months. This is another technique of radiation, which I just mentioned, called the hippocampal avoidance whole brain radiation treatment. This is a radiation plan over here on the side of the screen, and you can see that the hot spot of the radiation is avoiding this part of the brain here. These are the hippocampus in the brain, thought to really be involved in memory, and it's been shown to reduce the amount of neurocognitive effects of radiation treatment on a very large clinical trial. if I'm considering whole brain radiation treatment for a patient, I often will see if they might be a candidate for this approach. Stereotactic radiosurgery is my preferred approach for treating a brain metastasis with radiation. It's the delivery of very focal high-dose radiation treatment. We typically can give it in one treatment or up to 5 treatments. It's effective for a limited amount of intracranial disease. Limited is still to be defined. Some folks won't treat more than 5 or 6 brain metastasis. Our group at Duke will commonly treat up to 20 or more metastasis with this technique. It just really depends on the situation. These side effects from this treatment could include fatigue, headache, nausea, and then there's a risk of something called radiation necrosis, which I do want to talk about in just a bit. We know the stereotactic radiosurgery leads to less cognitive decline just because we're just radiating the individual spots on the brain. So folks tend to do better with that treatment. This treatment can often be repeated if new lesions arise. If one of the lesions starts growing back, sometimes we can give repeated radiosurgery, but that's a very nuanced situation that I'd want you to really review with your radiation oncologist and their multidisciplinary team to see if that's the best option for you. So what happens after you complete the radiation treatment? We typically do routine brain MRIs for every 3 to 6 months, typically every 3 months for the first 2 years. And then after that, we often will transition to every 6 months. This is to monitor for any new brain metastasis or potential radiation necrosis. And then patients will typically restart their systemic therapy if it was held during the radiation treatment. And that's a discussion that we have with medical oncology. I discussed a little bit about radiation necrosis. So this is a side effect of brain radiation. It occurs about 5 to 10% of the time. It's a late effect of the radiation treatment. It can cause an inflammatory reaction on the brain. The difficulty with radiation necrosis is it can also, on an image, look just like tumor recurrence. So it takes we take a very detailed approach with neuroradiology, neurosurgery, and radiation oncology here to try to determine if we think this is radiation necrosis or if we think it's recurrent disease. It can be symptomatic, and so we often will treat with some different therapies if patients are having symptoms. Those treatments are medical approaches that can include steroids such as dexamethasone, can also include an infusion called Avastin, which we will sometimes give. Pentoxifylline and vitamin E is a historic treatment for this, and it is given in some rare circumstances. And a newer emerging treatment is Boswellia serrata. So that is a treatment that has been explored very recently at Ohio State, and they're starting to publish some interesting data. And Duke is part of a multi-institutional study looking at Boswellia and Avastin in patients like this. There are surgical options if needed. Surgical resection is an option, and there's a newer treatment called LIT or laser therapy, which has been shown to help reduce radiation necrosis risk, and multiple clinical trials are currently ongoing with that approach. So whole brain radiation and SRS both show excellent response for brain metastasis and should strongly be considered in patients who have symptomatic brain metastasis. In the upfront setting, however, we do know that medications like Tagresso have very good cranial responses. So just like Dr. Alder's case earlier today, often we will start patients on that treatment first before setting them up for any radiation treatment if they have small or asymptomatic metastasis. We typically will get a quick MRI in about 4 to 6 weeks to assess response. And so a lot of patients we've been able to avoid giving radiation treatment in the upfront setting. So I do want to shift gears a little bit now and talk a little bit about leptomeningeal disease and potential radiation options. So leptomeningeal disease is cancer that has spread to the cerebral spinal fluid, and the leptomeningeals are the lining of the brain. and the spinal cord. And because it gets into the lining of the brain, there's nothing to really impede its spread, and it's easy for the cancer cells to kind of crawl around along these areas, causing significant symptoms, and it can have a very quick progression with a quick onset of symptoms. Unfortunately, it can sometimes be difficult to diagnose this. The signs and symptoms, there can be many of them. Those can include headache, changes in thinking, difficulty walking, nausea. There can also be eye symptoms or weakness. And then sometimes we can even see bowel or bladder dysfunction or incontinence. To diagnose it, our current approach is to move forward with an MRI scan. And if the MRI scan is negative, we then tend to do CSF or cranial spinal fluid sampling, which is a lumbar puncture as pictured here. The issue is only about 20% of patients who have leptomeningeal disease have actual positive cranial spinal fluid. Excuse me. 20% of patients have cranial spinal fluid that's positive, but it was not identified on a brain MRI. And the brain MRIs also can be very dependent on the neuroradiologist reading them. So often here we do have a multi-institutional group really look at these scans to see if we are concerned about patients with leptomeningeal disease. A single craniospinal fluid test can be falsely negative, and so sometimes multiple tests are needed. And we're currently trying to decide, what the best way to assess this in clinical trials. And it's also important to discuss on the clinical trials the time on treatment, the quality of life, and the symptoms improvements. One of the newer treatments for diffuse leptomeningeal disease or classical leptomeningeal disease is proton cranial spinal radiation treatment, where we treat the entire brain and spinal canal with radiation. This treatment has been reported in a phase 2 clinical trial that has shown some promising results. And this is a sample plan here comparing traditional radiation treatment with exposure to the entire body versus proton radiation treatment, which has a very brisk radiation dose fall off, where there's less exposure and less side effects. The phase 2 clinical trial showed that patients who underwent this treatment had a median survival about 8 months, compared to a traditional approach of about 2.5 months. And because of that degree and of benefit, there's currently a phase 3 trial that's being done around the United States called the NRG-BN014 trial. The problem is proton therapy is unfortunately very limited around the United States due to the cost of the facilities. They usually cost over $100 million. And currently there's about 46 operating facilities in the United States. And I'm not sure how many of them offer treatment for leptomeningeal disease at this time. In light of that, several groups have looked at delivering this treatment with our LINAC technology, which is widely spread throughout the United States. And at a recent meeting just 2 weeks ago, we've seen some very favorable results from that treatment. And it's something that we are considering more for patients.
All right,
Dr.
thanks, Trey, for that great overview of radiation. So a little bit more about leptomeningeal disease and treatments. This is from the NCCN guidelines. These are a few of the recommended things, but we need lots of improvement. So I kind of try to put together, and this was from a recent presentation, looking at the intracranial responses from some of the medications and the combinations we use for brain and the rest of the body, trying to really put together the responses that occur in the brain and specifically with leptomeningeal disease. The problem, as you can see, these are small numbers, right? And the studies had a little bit differing criteria of how often are they getting brain MRIs. So it's always a little bit tricky to compare different trials and kind of have to go into the details a little bit. But I think the overall view is the options are improving and we are getting more options. This is another slide. When someone is on such as something like Tagrisso and then they have leptomeningeal disease development, these are some of the options. I think in the chat I saw something, doubling the dose of the Tagrisso, going to 160 milligrams a day does seem like that has some good benefit in brain metastases and in leptomeningeal disease especially. So that can really improve the length of time in the medication and can kind of stabilize, prevent the disease from growing or spreading. There's also a little bit of data on amivantamab and lazertinib. Furmonertinib is another oral medicine that's used, again, more so in China and in some clinical trials in the US. And then some of you may have heard of intrathecal, like pemetrexed especially. That's when we actually inject the chemotherapy into the cerebral spinal fluid. The picture that Trey showed when we're getting that fluid out, it's kind of this similar thing of putting the chemo in. Sometimes it's done through a Maya reservoir. That's kind of an indwelling catheter in the brain. And that has some data that's up and coming that it can be one of the options. So this was the Bloom study. This was the doubling dose of the Tagrisso. And I like this slide because, as Trey mentioned, we know that leptomeningeal disease can be tough to follow just because it doesn't always show up on the images. Sometimes even the samples from the CSF can be tricky. There is some new technology using biomarker testing on the CSF fluid, actually. It's still kind of in development, but that looks promising. But I think really keeping an eye on neurological function, symptom improvement is really important. And one of the things that we're all trying to fight for include patients with leptomeningeal disease. We need this data. And as you can see here, the double dose of Tagrisso did help in those patients with neurological symptoms like headaches, dizziness, trouble walking. It did improve them. Another new trial I just wanted to quickly emphasize, this is out of Memorial Sloan Kettering. It's using amialaz with a very specific CNS focus. So this was phase 2. People had previously been treated with Tagrisso for the common mutations and chemotherapy for some of the uncommon ones. This was nice data because it included patients with active brain disease and leptomeningeal disease. We don't always have this data enough, but it did. And when we're looking at those response rates, that's when the cancer either completely went away or decreased. But we also have to look at stable disease, which we know is a big win. But when we look at the left of the graph, we see that patients are on these medications for a while. That was the duration of benefit. And so that is always promising when we see, 14.4 months survival on this type of medication, 8 months on this treatment. These are, again, only a smattering of some of the trials that have a CNS and quite a few of these leptomeningeal focus. We see new chemotherapy with sacituzumab combined with bevacizumab or Avastin. We see new TKIs, new oral drugs. We see using immunotherapy in an intrathecal fashion. We see things combined with Tagrisso. We see deferoxamine is a phase 1. And so lots of new medications. And that leads me to my last slide, is just there's so much hope. And I know sometimes it can feel really dark and really anxiety producing and really scary. And that's a very normal feeling. And when we talk about average length of survival, that's just an average. And what we're hoping is that we can continue to move that curve move these numbers more and more and more. We're all fighting the hardest we can. We would love to cure these things one day. We want to do everything we can to prolong survival. The best is yet to come. I believe that very much. And just a huge thank you to Jill for helping me organize this, along with so many others, to all of our advocates. And, biggest thank you is to our patients. Your grace, your courage, your strength just astounds me every single day. I love doing my job because it means learning so much from you, from my patients, from their families. You give us hope. You help us do our job every day and fight for new trials and new treatment options. I'm lucky that we have an amazing team at Duke, including me and Trey and so many others. And it was such a pleasure to be here with you today. And we're going to go to the Q&A. And I would also love to hear from Allison again, if we've missed anything, and then to bring on any and all questions. And I will stop sharing so we can see everyone's faces.
No, the only thing I would add is a huge thank you to both of the doctors as well as the coordinators, Laura and Jill. This is amazing, something I really wish I had had 7 years ago, but so nice to see this in today's day and age. So yeah, huge thank you to the entire group. Amazing.
Wow. Thank you. Thank you. Thank you. That was incredibly informative. A lot to digest. And we're really grateful to have, we can dive a little bit deeper into the Q&A. We have a lot of questions. So we tried to group them. We'll try to answer as many as we can. For those that we may not get to, we will try to get those answers after the fact, the unanswered ones, and maybe Dr. Alder and Mulliken can help with that and get those to you. But, one question that keeps coming up that I want to comment on, we hear a lot, why don't all oncologists recommend routine brain MRIs for people who don't necessarily have brain or CNS involvement at diagnosis? I am the patient advocate on the non-small cell lung cancer living guidelines. And by living guidelines, lung cancer are the first living guidelines, meaning we update them every 3 months. That's how fast things are moving. And really, the recommendation say it's unless, it's advanced stage or there are brain metastasis upon diagnosis, it really is recommended based on symptoms or risk. But as we talked about EGFR, there is a higher chance of it spreading to the brain. So I understand how that can be confusing for patients when practices vary so widely. And as a group, we always tell people to talk to your oncologist about it. And, if you don't feel comfortable, reach out to us, we'll help you, but you can ask for an MRI. Listen, there's no radiation with brain MRIs. And I agree. I think, I get them yearly. The yearly, it seems to be a consensus, but again, it's really advocating for yourself. But Dr. Alder, there's a few questions about how to understand resistant mechanisms when progression happens in the brain, whether it's, if it's leptomeningeal disease, you can do a lumbar puncture, get the information, which is not a great, comfortable way for patients. Hopefully there'll be easier ways. But when it's a brain met that isn't biopsied, what options are there to get insights into the biology of what that tumor may be or those tumor may be's? And are there emerging strategies to get around the challenge of people who don't shed, whose cancer, doesn't shed into the bloodstream. Like I would think, is there better, like cerebral spinal fluid analysis or advanced imaging? I don't know, if you could help us answer.
Yeah, it's a really great question, and that can be really difficult when there's only cancer growing in the brain or in the CSF, in the leptomeningeal space. A few things, imaging, brain MRIs are getting better and better. It's always okay to get a second opinion. Sometimes I think, as Dr. Mulliken mentioned, different neuroradiologists, so people who are really trained in reading like brain and spine images, can go a long ways in helping to review and helping you say, okay, what's going on? Does this worry us that this is cancer or not? I always like to get one of the liquid biomarker assays. There's a lot of different companies, Guardant, Tempus, Foundation One, etc. If that is negative, sometimes I involve like Trey and be like, hey, Trey, if they're only evolving in the brain, if the growth is only there, can we radiate and continue on whatever treatment they're already on, like Tagrisso or anything else? And so I think teamwork, makes the dream work. It's always great having multiple opinions and thoughts, especially from people who you trust a ton, like I do with Trey, and then making sure that we have the best path. If it is something that maybe we can't radiate again, always want to get biomarker testing if we can. If that seems impossible, then maybe we'll go to an option that works regardless of resistance, like Dato-DXd, Datroway now. That works in all comers with EGFR. There is some technology that is looking at sequencing the CSF liquid. And I think overall, a lot of these technologies, both blood, tumor, eventually CSF, they're getting better and better. When we first got these tests, how well they captured even a few tumor cells was iffy, but they've gotten so much better even in the couple of years. I meet with these companies and they're always showing me, I can't wait to show you like how much better our test is, and like they're competing with each other, which I'll take it. Yeah, go ahead and compete with each other and make these tests even better. And so lots of new things along the way, but lots of different options. And I think it goes down to every single patient we see, they're unique. My aim is personalized treatment for that person sitting right in front of me.
Yeah, no, that's great. And I think, I have a question for, both you, Allison, and you, Dr. Mulliken, along from what you said, Dr. Alder. And Allison, your mom did not have a brain MRI off the bat, right? She was early stage. What would you recommend? What would you recommend to people who don't have it off the bat? How did you advocate for your mom?
Yeah, I think my dad told me once that it's okay to be shy on a first date, but there's no room for shyness in the doctor's office. And I think that's very true. This is a life or death situation in all honesty. And so it's just important that to get the information, first of all, from webinars like this. And then if you can't get what you want from the doctor that you have, seek out another one, These things are kind of time critical. And so yeah, I think it's important to advocate for yourself. And if it's too hard to go through one path, I would just say find another path.
Yeah. I always say, you literally, if you're the CEO of a company, you would not let anything go, without dotting the I's and crossing the T's. But the vulnerability, even if you are a CEO of your company, the vulnerability when you're faced with, this disease, it literally crumbles people. And that's, our goal is to empower people and arm them with what they need to be able to have those open, honest communications. Yeah, thank you. Dr. Mulliken, Dr. Alder at one point said, if we can radiate again, a question that people always have is, how many times can the same area be safely, have radiation with, I would say, stereotactic body radiation therapy, as opposed to whole brain radiation therapy.
Yeah, so we get that question a lot too. It's a very nuanced question, I will say. So this is one of those things you can ask a 10 radiation oncologist and get 15 different answers. So normally, if a patient's had whole brain radiation before, stereotactic radiosurgery is safe. So if you've had whole brain radiation and then develop a new lesion, doing radiosurgery is an option. And that's actually how radiosurgery was actually developed in that setting. The original trials were done after whole brain radiation. So that's definitely safe. In a spot that has seen radiosurgery before, and then we're questioning whether or not we want to do additional radiosurgery, it is very institutionally dependent. Our practice here has often been to try to get a biopsy or some tissue just to prove that there's recurrence there, because this could just be radiation necrosis. That does happen up to 10% of the time, sometimes even higher, depending on how big the lesion was. And giving more radiation to radiation necrosis is just going to make a problem worse. So we often, if we can, really try to get a biopsy before going to repeat radiation treatment in that setting. All in all, I do repeat radiosurgery after previous radiosurgery treatment. I probably have maybe 1 or 2 cases every month or so. So it is something we do routinely in our center, and most academic centers would offer that treatment.
Okay. And, kind of 2 questions. What would people need to be aware of in terms of the risks, but also along, kind of the same lines with leptomeningeal disease? The question is there an stereotactic radiation, therapy for leptomeningeal disease when it's in the fluid, not necessarily tumors?
Yeah, so we've learned a lot about leptomeningeal disease over the last 5 to 10 years, even in the last 5 years. And we didn't get into this just given the time constraints, but we are now subclassifying leptomeningeal disease into different settings. The leptomeningeal disease we were really discussing today is the diffuse or classical leptomeningeal disease, where it's kind of spread over the brain or potentially the spinal canal. There's another type of leptomeningeal disease called nodular leptomeningeal disease or focal leptomeningeal disease. It looks like leptomeningeal disease on the image, but that's the only spot. And that's a specific situation where I have offered radiosurgery before, and other practices have validated that as a good approach because it does avoid the whole brain radiation treatment. So it's important to have that discussion with your radiation oncologist, because when you read your MRI report, it might just say leptomeningeal disease. But you really want to have the radiation oncologist, when you see them in consultation, at least comment, do you think this is focal leptomeningeal disease, or do you think this is diffuse? Because that can really change your treatment options. Thank you,
Yeah,
Joe.
that's a really great point. And I think in general with, what the radiology report says and what is actually happening, right? It's not that the radiology report is wrong. It's just the radiology report doesn't have context necessarily of that individual patient. And that leads to a common question that has come up too, kind of, I guess, there are a lot of challenges in diagnosing leptomeningeal disease early and accurately. And so in cases without obvious clinical or MRI signs of leptomeningeal disease, what is it reasonable, or is there any value in doing CSF testing proactively, or an MRI to see if there are any evidence, if there's any evidence. And those are really two questions kind of, combined into, what the challenges in diagnosing. And also, obviously it's a fear of all of us. So we want to be proactive, but how do is that even possible for both of you, whoever, but.
I think at this point, routine CSF testing is not indicated in the absence of symptoms. If you're just going along on Tagresso and everything's going fine, just coming in for routine CT scan, routine MRI, I don't think adding on an LP at this time would be indicated. It's an invasive procedure. There's always a risk of complications afterwards. A lot of patients wouldn't like that procedure either. And so I don't think routine testing for that is indicated. But I think just having, if you're having new symptoms, headaches, nausea, vomiting, new symptoms with arms or leg issues, really just bring it up to your oncologist, your radiation doctor, or your medical oncologist, just to make them aware.
Yeah, absolutely. And Dr. Alder, what advice can you give people, especially, I'm sure you have patients who fear that, and how do you talk to patients and families about that?
Yeah, I like to be upfront and tell them, this type of disease does have a chance of spreading to the brain. And I always say, I think Allison said this too, you know your body best. And so I want to know about any changes, about anything that my patients ever feel is off, or if they've noticed anything new or different. Because the sooner they tell me, the sooner that we can kind of work it up. And so as Dr. Mulliken was saying, if we need to get a sooner brain and or spine MRI to really make sure we're not missing anything with any new symptoms that are developing, then that's really important that we do that quickly and that we jump on it.
Okay.
And then thankfully with the treatments that we have nowadays, we're doing a better job of preventing some of these of both brain and LMD from ever developing, which is really, really encouraging. I think that was some of the best data from both the when we add on to osimertinib, when we either do chemotherapy plus OC or amivantamab plus lazertinib, is we're preventing some of these brain and spine metastatic developments from even happening, or at least, so I think that's really encouraging too.
I agree. A couple of years ago, there was absolutely nothing happening, I feel like, in this space. And, the true value of research for patients and families is hope. And so there definitely is more hope. So we have a question that actually a lot of people talk about as well, is what's the current evidence on proton therapy for treating LMD, and kind of what the challenges and limitations are now, and where we see it going.
Yeah, no, it's an exciting treatment, I will say. It still needs to be validated on that phase 3 trial. So if you are a trial candidate, I would strongly encourage participation. The issue with proton therapy is there's not a lot of places that do it. Duke doesn't have a facility. We have to refer out. I have referred out for it before, in 2 patients with EGFR-driven LMD. Insurance approval has been challenging. Proton therapy is more expensive than traditional radiation treatment. And it also takes a lot of, the treatment itself actually takes a lot of time. It takes about an hour and a half of you lying flat on a table still to give the treatment. And because proton therapy is a limited resource, not a lot of facilities are routinely doing the treatment. Proton therapy is very well validated in treating children with cancer or young adults with cancer just because of the less exposure. And so those patients always take priority for the treatment. In light of that, myself and other folks have really been looking at our widespread radiation technology, the linear accelerator, to deliver the CSI treatment. It's treating the same area as the proton therapy. There's just concern there could be some more side effects with it. At our recent meeting, national or international meeting, it did appear that the folks doing that treatment with our traditional radiation machinery were seeing a similar outcome, and the adverse effects actually seemed to be pretty well tolerated. So I have discussed that with a couple patients here at Duke as an option. And I have not personally pursued that yet, but that using what is already a widespread technology probably be more accessible to a lot of folks.
Great. That's good to hear, knock on wood. And as we're along the lines of adverse events, side effects, Allison, obviously your mom has gone through the ringer with this. And, some people were asking, what is the typical timeline for fatigue? Or is there anything that helps, patients with that or other side effects, to get them back to as close to normal as they can sooner? Are there any side effects that aren't, always, they're not written in the book, so to speak? Like I know personally, the last time I had SBRT, I had a metal taste in my mouth, right? I had it in the chest, not the brain, but my radiation oncologist said, well, technically it's not written in the books, but there's enough patients that have said that. So, just for information, Allison, if you could talk a little bit about common side effects, not so common ones, and maybe what your family did to help your mom get back in shape.
Yeah. Yeah, so as you said, my mom's been through many different treatments, I guess. She did start on osimertinib, but she also entered a clinical trial. She also had SRS, radiation. She is on amivantamab. She also had intrathecal pemetrexed. So, yeah, she's gone through a number of different treatments that I think have gotten her to today. And to your point, at each one of those steps along the way, there have been different side effects that she's experienced. I think a more general statement I might be able to make would just be that the side effects are different for every patient, right? So um, when you hear about certain side effects that are extreme, you might not experience them, and the reverse as well, right? Like you might have a very extreme reaction, and there have been cases of that where she's been on a clinical trial and she'd had to lower her dose, for example. She's a smaller woman, so I think also the dosing is taking into account there. So just in terms of that, I think it's been really helpful, like at each treatment along the way. She's, maybe started off with some very off-putting side effects, but with her medical team have been able to try to, best as you can, address some of those side effects so that the longer she's on the treatment, the better she actually feels. And hopefully each treatment along the way just kind of brings her closer and closer to what, we've discussed, I think, on this call, which is hopefully better and better medications that have less off-target effects and, maybe one day have a curative intent.
Yeah. From your mouth to God's ears, right?
Yeah.
Well, oh my gosh, time goes so fast. I know there are definitely questions that we didn't get to. Again, we will hopefully, we'll get to them and we could get those to you. But as we wrap up, I just want to say thank you. Thank you to our speakers thank you for your time, your expertise. your compassion and willingness to, talk to the community. And to everyone who joined today, thank you for joining us. And thank you to our team, CMS, for really bringing this all together. I hope that today's conversation, it helps you understand, understand the disease better, empower you to ask those hard questions, push for better options, make sure you have the information to make, informed decisions. And most importantly, I hope you all know you don't have to do this alone. So this session was recorded and we'll be sharing it. Please provide feedback. We welcome any and all. And if you have ideas for future topics, we have a laundry list, but we want to hear any topics that you think would be helpful. And for those that are attending the EGFR Resistors in person Patient and Caregiver Summit next month, we look forward to seeing you. For those who can't, there is a virtual option. So actually, I will put the link in the chat right now. But really, truly, thank you for joining us. And and take care. And hopefully everybody has a great fall.